Clay, a 17-year-old male, arrives at the clinic after noticing that he's not developing like his friends. On further questioning, Clay mentions that he was born without a sense of smell. Upon physical examination, you notice that he has no facial or body hair, and that his external genitals are small and underdeveloped for his age. You decide to run a blood test, which shows low levels of the hormones GnRH, LH, FSH, and testosterone. Finally, you order a semen analysis, which reveals a low sperm count. Next comes Jessie, a 13-year-old girl, and her concerned mother, who's noticed that Jessie has started to develop some masculine features, such as a deeper voice and excess body hair growth. A blood test shows increased testosterone levels and low dihydrotestosterone, so you decide to perform a karyotype test, which reveals 46 chromosomes, with one X and one Y chromosome. Okay, now, based on their initial presentation, both Clay and Jessie seem to have some form of disorder of sexual development and sex hormones. But first, let's go over some terminology. On the one hand, we all have a genotypic sex, which is determined by our karyotype, or set of chromosomes. Generally, there are two sex chromosomes. Those who have X and Y sex chromosomes are typically considered genetically males, while those who only have X chromosomes are typically considered genetically females. On the other hand, phenotypic sex is determined by the primary sexual characteristics, so the genitalia and gonads, as well as the secondary sexual characteristics, such as breast and muscle development, as well as body hair and fat distribution. The development of primary and secondary sexual characteristics is generally under control of the hypothalamic pituitary gonadal axis. First, the hypothalamus secretes gonadotropin-releasing hormone, or GnRH for short, which goes to the anterior pituitary to stimulate the release of gonadotropic hormones, which are luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH. LH and FSH then stimulate the gonads to produce sex hormones. In males, LH stimulates the Leydig cells of the testes to secrete testosterone, and FSH stimulates the Sertoli cells to secrete inhibin B. Testosterone and inhibin B are responsible for the development of male primary sexual characteristics, like enlargement of the penis and testes, as well as male secondary sexual characteristics, such as a deepening of the voice, a male pattern of hair growth on the face, chest, axilla, and genital areas, and increased muscle mass. On the other hand, in females, LH and FSH stimulate the ovaries to secrete estrogen and progesterone, which are responsible for the female primary sexual characteristics, like ovulation, menstruation, and uterine development, as well as female secondary sex characteristics, like breast development, hip widening, and hair growth, mainly on the axilla and genital areas. Now, once sex hormones have done their job, they signal the hypothalamus and pituitary via negative feedback to turn off the secretion of GnRH, LH, and FSH. Now, disorders of sexual development, or DSD for short, are characterized by a discrepancy between an individual's genotypic and phenotypic sex. Let's say there's an individual that has a 46XY karyotype, so they're genetically male, and they have testes, but their external genitalia show a feminine or ambiguous appearance. So this is called a 46XY DSD. The opposite scenario would be an individual with a 46XX karyotype, so they're genetically female and have ovaries, but present with virilized or ambiguous external genitalia, and this is called a 46XX DSD. The previous terminology for DSDs includes terms like hermaphrodite or pseudo-hermaphrodite. However, these terms can be considered derogatory, so they're no longer in common use. And although currently the most widely used term is disorders of sexual development, keep in mind that it's also falling out of favor, since it's considered overbroad, and the word disorder may have a negative connotation. So don't be surprised if there's a new term in the future. For your exams, some high-yield disorders of sexual development and sex hormones include ovotesticular disorder, androgen insensitivity syndrome, 5-alpha reductase deficiency, placental aromatase deficiency, Kallmann syndrome, precocious puberty, and androgenic steroid abuse. Let's start with ovotesticular disorder. Now, the cause of this disorder isn't totally clear. What's important for your exams is that most individuals with ovotesticular disorder have a 46XX karyotype, so they're genetically female. But keep in mind that it can also affect individuals that are 46XY, as well as those who have a mosaic karyotype, where some cells are 46XX, while others are 46XY. Now, as the name suggests, individuals with ovotesticular disorder have a mixed phenotypic sex. Most affected individuals present with ovotestis, which is a gonad made up of a combination of ovarian and testicular tissue. On the other hand, some affected individuals may develop an ovary on one side and testis on the other. In addition, individuals with ovotesticular disorder usually have ambiguous genitalia, meaning that the appearance of their external genitalia isn't clearly male or female. Previously, ovotesticular disorder was called true hermaphroditism, after the Greek god Hermaphroditus, who was united with the nymph who fell in love with him into a single body with both masculine and feminine characteristics. Nowadays, this term is no longer used. Next, we have androgen insensitivity syndrome, which is the most common form of 46XY DSD. This is caused by a mutation in the androgen receptor gene, which is found on the X chromosome. Androgen insensitivity syndrome is an X-linked recessive disorder, so it typically affects genetic males because they only have one X chromosome. On the other hand, genetic females generally have two X chromosomes, So even if they have a defective gene on one chromosome, they still have another functional one. Okay, normally during the first trimester of fetal life, the gonadal sex develops either into testes or ovaries. In males, a gene on the Y chromosome, called the sex-determining region Y, or SRY gene, helps the fetal gonads turn into testes, which are initially located in the abdomen. In turn, the testes start producing androgens, the main one being testosterone. A small fraction of testosterone gets converted by the enzyme 5-alpha reductase into its more potent form, called dihydrotestosterone, or DHT, which is mostly responsible for development of male external genitalia. And that's a high-yield fact. Internally, there's a set of ducts called Wolffian and Mullerian ducts. Testosterone also causes the Wolffian ducts to differentiate into the male reproductive system. At the same time, the testes also produce a hormone called anti-Mullerian hormone, which prevents the Mullerian ducts from developing into the female reproductive system, and instead makes them degenerate. During the third trimester, testosterone helps the testes descend from the abdomen into the scrotum. On the other hand, in females, there's no Y chromosome, so the SRY gene is absent. As a result, ovaries develop from the internal gonads, and androgen levels remain relatively low, so they develop female external genitalia. Now, individuals with androgen insensitivity syndrome have normal functioning testes that produce androgens, but these hormones can't exert their action because there's a defect in the androgen receptor. Without the effects of androgens, the testes sometimes don't descend into the scrotum, and instead remain in the abdomen or pelvis, which is called cryptorchidism. What's important for your exams is that cryptorchidism is related to a higher chance of developing testicular cancer later in life. Additionally, with androgen insensitivity syndrome, the genitals develop an overall feminine appearance, with a rudimentary vaginal opening, and a normal-looking clitoris and labia. Even though androgen influence is missing, the testes still produce anti-Mullerian hormone, which means that these individuals don't have a uterus and fallopian tubes, and thus their vagina ends in blind pouch. During puberty, some of the excess androgens may end up being converted to estrogen by the enzyme aromatase. As a result, affected individuals may develop female secondary sex characteristics, such as widening of the hips, gynecomastia or breast growth, and scant pubic and axillary hair. Androgen insensitivity syndrome can sometimes remain undiagnosed until puberty, when an individual that has female genitalia doesn't start menstruation. And on a blood test, individuals with androgen insensitivity syndrome may have increased levels of testosterone, estrogen, and LH. Finally, a karyotype test can be done to confirm the genotypic sex. Treatment typically involves surgical removal of the testes, especially in the case of cryptorchidism, to reduce the risk for cancer. In addition, individuals who choose to adopt a female gender identity can use estrogen supplements, while those who adopt a male gender identity can use testosterone or DHT supplements. Another high-yield 46XY DSD fact is 5-alpha reductase deficiency, which is caused by a mutation in the SRD5A2 gene. What you need to know is that this gene codes for the enzyme 5-alpha reductase, which normally converts testosterone to DHT. For your exams, remember that 5-alpha reductase deficiency is inherited in an autosomal recessive but sex-limited pattern. This means that for the disease to appear, both copies of the gene have to be mutated, and the individual has to be genetically male, since dihydrotestosterone has no role in female sexual development. And that's very high yield. With 5-alpha reductase deficiency, the problem arises in a male fetus where the testes produce testosterone, but isn't converted into DHT. As a result, they develop male internal sex organs, but the external genitalia appear ambiguous or female. In particular, the penis doesn't fully elongate, and the scrotum often remains split in two, which is also called a bifid scrotum. When these individuals reach puberty, there's a huge testosterone surge. So even though it can't be converted to DHT, there's so much testosterone around that the penis and scrotum grow larger and start acquiring a masculine appearance. In addition, individuals start developing a deeper voice, muscle growth, and facial and body hair growth. Diagnosis of 5-alpha reductase deficiency is usually suspected in newborns with ambiguous genitalia, and a karyotype can be performed to confirm the genotypic sex. What's high yield is that blood tests usually show normal serum testosterone and estrogen levels, low DHT levels, and normal or increased LH levels. Treatment of 5-alpha reductase deficiency is focused on hormone replacement therapy. Moving on, placental aromatase deficiency is a 46XX DSD caused by a mutation in the CYP19A1 gene, which codes for the enzyme aromatase that normally converts androgens to estrogens. Now, placental aromatase deficiency is also inherited by an autosomal recessive but sex-limited pattern. But unlike 5-alpha reductase deficiency, this mainly affects genetically female individuals, since estrogens are the main female sex hormones. And that's very high yield. Now, during gestation of a baby affected with placental aromatase deficiency, the abnormally high androgen levels from the fetus can cross the placenta into the mother's bloodstream. As a result, there's maternal virilization, which is characterized by deepening of the voice, hirsutism or excessive body hair growth, and acne or multiple skin pimples mainly involving the face. Keep in mind that maternal virilization usually regresses after giving birth when the fetal androgens aren't around anymore. Now, infants with placental aromatase deficiency have ovaries internally, but their external genitalia look ambiguous or masculine. At puberty, they develop progressive virilization, associated with a lack of breast development, and amenorrhea, or absence of menstruation, which leads to infertility. In addition, these individuals may often develop multiple ovarian cysts, which are fluid-filled sacs in an ovary. Blood tests in placental aromatase deficiency show very low serum estrogen levels, as well as increased serum testosterone and androstenedione, which is an androgen precursor. Treatment can involve hormone replacement therapy with estrogen. Switching gears, Kallmann syndrome is a genetic disorder of sexual development with unclear inheritance patterns that can affect either genetically male or female individuals. Normally, during fetal development, there's a region of the brain called the olfactory placode, from which two groups of neurons emerge. The first group contains olfactory neurons, which migrate down from the olfactory placode and get embedded in the cribriform plate. This bone plate separates the nasal cavity from the brain and serves as a base supporting the olfactory neurons, which form the olfactory bulb that senses smells. The second group contains GnRH neurons that release gonadotropin-releasing hormone, or GnRH. These neurons migrate through the cribriform plate and settle into the hypothalamus. In Kallmann syndrome, there's a defect in the migration of the olfactory placode neurons. That includes the olfactory neurons, leading to hyposmia, which is the reduced sense of smell, or even anosmia, which is the complete loss of smell. It also includes the GnRH neurons, which results in a decreased GnRH secretion by the hypothalamus. As a consequence, the pituitary is not stimulated, so there's low levels of the gonadotropins LH and FSH. This ultimately results in hypogonadotropic hypogonadism, meaning that there's decreased gonadal function due to a lack of stimulation from the hypothalamus or pituitary. And that's a high-yield fact. In males, this leads to a decrease in testosterone, while in females, there's a decrease in estrogen and progesterone. This disruption in hormones prevents puberty from beginning or successfully completing, leading to underdevelopment of primary and secondary sex characteristics. In males, primary sex characteristic dysfunction includes having a small penis and testes, as well as a low sperm count. On the other hand, secondary sex characteristic dysfunction includes a lack of facial hair, low muscle mass, and not developing a deep voice. In females, the most important primary sex characteristic dysfunction is amenorrhea, while secondary sex characteristic dysfunction includes a lack of breast development and pubic hair. In addition, what's high yield is that in both sexes, Kallmann syndrome often leads to infertility. Diagnosis of Kallmann syndrome involves blood tests revealing low levels of GnRH, LH, FSH, and sex hormones. What's important to note is that the levels of other pituitary hormones remain normal. Treatment is mainly focused on hormone replacement therapy to help stimulate puberty and the development of secondary sex characteristics. On the flip side, there's precocious puberty, which is characterized by the development of secondary sexual characteristics at an earlier age than the average. Generally, puberty is considered precocious if it begins before the age of 8 in females and the age of 9 in males. And that's something you must absolutely remember. Now, precocious puberty can be classified in two types, central or peripheral. Central precocious puberty results from early maturation of the hypothalamic pituitary gonadal axis. When that happens, there's an increased secretion of GnRH, which ultimately causes an increase in sex hormones. Most of the time, central precocious puberty is idiopathic, meaning there's no clear cause. Less frequently, central precocious puberty may result from a hypothalamic tumor that's releasing GnRH. On the other hand, peripheral precocious puberty is the result of an abnormal overproduction of sex hormones by the testes or ovaries. But unlike central precocious puberty, it's GnRH independent, and that's very high yield. Now, peripheral precocious puberty could be caused by an ovarian or testicular cyst or tumor that's oversecreting sex hormones. Peripheral precocious puberty can also be caused by genetic conditions like congenital adrenal hyperplasia, which is an overgrowth of the adrenal glands that ultimately causes them to produce more androgens, as well as McCune-Albright syndrome, which is characterized by a hyperfunctioning endocrine system. Finally, keep in mind that peripheral precocious puberty can be the result of exposure to exogenous sex hormones from medications or creams. Now, the key feature of precocious puberty is early development of secondary sexual characteristics. In males, this typically includes premature adrenarche, which refers to the development of typical masculine hair growth, body odor, and acne. On the other hand, females may experience premature thelarche, or breast development, as well as premature menarche, which is the first menstrual period. In addition, both sexes may present with acceleration of linear growth, meaning that they typically have an early growth spurt. Also, precocious puberty is associated with early somatic or physical maturation, as well as skeletal or bone maturation, so these children may be taller than their peers. However, the epiphyseal plates of the long bones tend to close prematurely too, ultimately resulting in short adult height. Precocious puberty is diagnosed using the Tanner scale, which is a predictable set of steps that males and females go through as they develop primary and secondary sex characteristics and become sexually mature. Treatment of central precocious puberty can involve GnRH agonist medications to block pubertal development, while treatment of peripheral precocious puberty depends on the underlying cause. Last but not least, there's androgenic steroid abuse, which causes an acquired disorder of sexual development. Androgenic steroid abuse refers to the misuse of anabolic androgenic steroids, which are synthetic substances that can activate androgen receptors and can be taken orally, applied topically, or can be injected either intramuscularly or subcutaneously. Anabolic androgenic steroids tend to increase muscle size and strength and promote erythropoiesis, meaning they increase red blood cell production. As a result, some individuals use androgenic steroids illegally to improve their athletic performance. However, when androgenic steroids are misused, they can lead to many undesired effects. In females, androgenic steroids can cause virilization, which includes hirsutism and male pattern baldness, which involves the crown of the scalp. In addition, some females may experience menstrual irregularity, breast atrophy, and may develop acne. On the other hand, in males, excessive androgen levels can inhibit the hypothalamic pituitary gonadal axis via a negative feedback mechanism. This ultimately leads to a decrease in intratesticular testosterone, and thus gonadal atrophy, which is characterized by testicular shrinking, and low sperm count or even azoospermia, which is a complete absence of sperm in the semen. In addition, some of the excess androgens may be converted into estrogen by the enzyme aromatase, leading to gynecomastia and acne. Finally, some individuals may experience behavioral changes, such as aggressiveness or mood swings. For diagnosis of androgenic steroid abuse, blood tests show high hemoglobin and hematocrit levels due to the increased erythropoiesis. In addition, individuals would have increased levels of exogenous testosterone, along with decreased levels of LH and FSH. All right, as a quick recap, disorders of sexual development are characterized by a discrepancy between the phenotypic sex and the gonadal sex. Ovotesticular disorder is a condition that mostly affects individuals with a 46XX karyotype, who develop ovotestes and ambiguous genitalia. Androgen insensitivity syndrome is an X-linked recessive condition caused by a loss of function of the androgen receptor and affects XY individuals who develop testes that sometimes don't descend into the scrotum, which is called cryptorchidism, and their external genitals present a feminine appearance. 5-alpha reductase deficiency is an autosomal recessive disorder affecting 46XY individuals and results in a male fetus being unable to convert testosterone into DHT. This leads to male internal organs and ambiguous external genitalia. But when these individuals reach puberty, there's a huge increase in testosterone that causes masculinization. Placental aromatase deficiency mainly affects 46XX individuals that have a mutation in the enzyme aromatase, resulting in very low estrogen levels, as well as increased testosterone and androstenedione, which cause masculinization. During gestation of a baby with placental aromatase deficiency, the fetal androgens may cause maternal virilization. Kallmann syndrome is characterized by decreased or complete loss of smell, as well as hypogonadotropic hypogonadism, with decreased levels of GnRH, FSH, LH, and sex hormones, leading to low sperm count in males and amenorrhea in females. Precocious puberty indicates an early development of secondary sexual characteristics, typically before the age of 8 in females and before the age of 9 in males. Central precocious puberty is characterized by increased GnRH secretion, while peripheral precocious puberty is characterized by a GnRH-independent increase in sex hormones, which may be caused by an ovarian or testicular tumor, genetic conditions, or exposure to exogenous sex hormones. Lastly, androgenic steroid abuse is caused by misuse of anabolic androgenic steroids, which results in increased muscle size and strength, and high hemoglobin and hematocrit levels, as well as virilization in females and acquired sexual development problems such as gynecomastia, testicular shrinking, and low sperm count. Clay is a 17-year-old male who's experiencing delayed sexual development. He hasn't grown any facial or body hair, and his external genitals are small and underdeveloped for his age. This should already make you think of delayed puberty. In addition, Clay's low sperm count, together with the decreased levels of GnRH, LH, FSH, and testosterone, all point to hypogonadotropic hypogonadism. The final clue is the fact that Clay was born without a sense of smell, which is very characteristic for Kallmann syndrome. Next, there's Jessie, a 13-year-old girl who's experiencing masculinization, with changes like a deeper voice and increased body hair. This indicates that Jessie has a disorder of sexual development, which, according to her karyotype test results, is a 46XY DSD. This means that Jessie is in fact genetically male. An important clue for diagnosis is that Jessie's blood testosterone levels are high, which is causing masculinization now that Jessie has reached puberty. But the key here is that the DHT levels are low, which is typical of 5-alpha reductase deficiency.